It truly is my great pleasure to introduce my friend and colleague, Professor Mark Schutta from the University of Pennsylvania, to give today's endocrine grand rounds. We have several colleagues here who have spent some time at Penn, and I'm sure it's a pleasure for them too, Nina and Iyad, to see Mark again. So let me do away with some of the particulars, and then I'll throw some personal notes in. But Mark grew up in an academic medical family. His father was a well-known academic neurologist. In fact, Mark Schutta has rubbed shoulders with Dr. Roger Bannister, for those of you who are history buffs. The first human to break the 4-minute mile was a good friend of Mark's dad, and so Mark met him and interacted with him several times. Anyway, Mark grew up in the Philadelphia and New York areas where his dad had different academic positions. Then he attended the University of Wisconsin, where he was a political science major. And after that, he worked on Capitol Hill. And those of you with any knowledge of history, he worked with Congressman Les Aspin, who was a very influential congressman and later a Secretary of Defense, I think.
That's right.
And there, Mark rekindled his interest in medicine, instilled by his father's example, and he went to Thomas Jefferson for medical school and residency. And then in 1997, he went to the University of Pennsylvania for his endocrinology fellowship, where he's been ever since. Mark and I have rubbed shoulders several times going back over 15 years. I think the first time was when I was still an islet transplanter, and I served on a thesis committee with for Dr. Mike Rickles, who's spoken here, with Ali Naji as his mentor. But then also Carl June, who many of you know, he spoke here a few years ago, invited me to give a talk at Penn several years ago. And again, I got to meet with Mark. I've always been impressed with his character and his patient focus. And he and I know, think alike, that believe it or not, the way we take care of diabetes today is not perfect in every way in the medical systems. And so I could think of no better person to speak to us about his reflections as a frontline soldier in this war, as the director of the Rodebaugh Diabetes Center, than Mark. So you can see the title of his talk. Mark, we're very excited to hear your talk. Thanks for doing it, and the podium is yours.
Wow, thanks so much, Dave, for the kind introduction, and it's a pleasure for me to be with all of you today. As Dave mentioned, as a guy who runs a diabetes center, I'm constantly frustrated and thinking about things that are not working properly and how we can make them better. And as I kind of come to the latter part of my career, I think that what I'd like to really devote myself to is finding ways to make things better for our patients, because that's really what it's all about. And so this is the first time that I'm giving this talk, and I joked with Dave and Adam before the talk that this is a small topic and not very complex. Obviously, this is huge. There's so many factors in play here. What I'm going to try to do is provide some observations of things that I see all the time, and maybe some interventions that we've put forth. And I'd like to just sort of spend some time talking about this, but also get some reflections from all of you and ideas, because I think all of us who take care of diabetics need to be spokespeople and advocates for change, right? I have this conversation all the time. We know the system's broken. The healthcare system is broken. The way we take care of diabetics is not effective. But we are not going to fix the healthcare system tomorrow, right? And that's something that I learned from Dave Harlan. So we have to do workarounds and figure out other things. If you'd like to ask a question as we go along, please don't hesitate to do so. I'd like this to be informal. Again, this is my perspective. I will have some data, but I also, again, would like to have a discussion with you guys. So just a disclosure, my wife is an executive scientist at Merck and does early stage drug development. I'm sorry. So this is our group. This is the Penn Rodebaugh Diabetes Center, where we take care of 9,000 to 10,000 visits per year and roughly 4,000 to 5,000 patients. And like you guys, this requires a lot of people who are really dedicated and really loyal. And you can see everyone has smiles on their faces because they're posing for the camera, but we have a lot of days where we're not feeling so great about how we're functioning and what we're doing for our patients. So here's my argument for change. And I just want to emphasize that this is pre-COVID, because I'm sure all of you guys have had the same problem where a lot of patients have sort of slipped through slipped through the cracks during COVID. But these were 3 patients who I saw on 1 week on the inpatient service. So the first one's a 53-year-old type 2 diabetic man treated with metformin and glipizide. His last visit with his primary care doc was 17 months prior to his admission to the hospital, when his A1C was 9.2. He was never referred for diabetes education. He gained 12 pounds since then, and his BMI was 31.5. He presents to the HUP, that's Hospital of the University of Pennsylvania, ER, with an ischemic stroke with hemiparesis and dysarthria, right? 53-year-old man, A1C 12.4%. Here's a 61-year-old woman. This was 2 days later. Metabolic syndrome treated with metformin only. A1C 12 months ago was 6.5%. Reports polys, blurry vision, unexplained weight loss for months. Didn't reach out to anybody. Never had diabetes education, and her BMI is 33.2. Sounds like a vulnerable person who should get some intervention. Presents to the HUP ER with an ischemic stroke, hemiparesis. Okay. A1C 13.1%. 24-year-old woman with type 1 diabetes presents to the emergency room in diabetic ketoacidosis. Her bicarb was 5 and her pH was 6.5. I have never seen that before in my life, and I thought that was incompatible with life, and that woman survived. What had happened to her was she ran out of her insulin 2 days prior. Her A1C was 8.6%. She had frequent hypoglycemia. She was not on a CGM and told us that she monitors her blood sugar occasionally. Have you guys experienced patients like this? Unfortunately, we see them more frequently than we should. So to me, these are just 3 examples, and they are a little bit extreme, but they're not uncommon in an urban environment where I work. So I think all of you guys know that the cause of death in people with diabetes, #1 is ischemic heart disease. And you know, the thing that troubles me about this is that there's been incredible progress made in the treatment of cardiovascular disease, cardiovascular prevention, et cetera, except for in the realm of patients with diabetes. We really have not done a great job. And this is the thing that all of us care about the most. Just before this visit, I had my last morning clinic. My last patient was a 20-year-old student who's a type 1 diabetic college student on a Tandem X2 pump and a Dexcom G6. His A1C in college, which that's a tough time for kids, is 6.7. And I told him that he will probably never get any complications from diabetes, and the technology is only going to get better, and he probably won't need to see me, an endocrinologist, very frequently at all. So as a little snapshot of diabetes, this is data that I think all of you know, but there are a couple of things that I just want to point out here. We have 34.2 million people who have diabetes, and we have 40 million who are going to be diabetic in 2030, 60 million in 2060, right? So we've got a huge problem, not only on our hands right now, but it's getting worse, and we're going to be drinking from a fire hose, and we really don't have the tools to do anything about this. Dave Harlan always tells me and makes this point, it's a really good one. We are currently spending $327 billion on diabetes care. We're not going to get much more money than that, right? And the truth is, compared to other countries, we overspend and we're not doing a very good job. This shows you, it's an evaluation of diabetes care in the United States from 2005 to 2016, where you would think, having sort of been part of an epidemic of diabetes, that we would have gotten our act together and done better. But if you look at patients with achieved target percent in glycemic control, this is, as you go to the lighter shades here, we're doing worse as time goes on, not better. We're not even holding serve when it comes to glycemic control. We do pretty well with blood pressure. We do pretty well with cholesterol control. But when you combine, this should be over a little further, but when you look at combined blood glucose control, cholesterol, not doing very well at all, and we're even worse when you combine all three of these modalities, okay? And then if you look down here in the bottom panel over on the right, the 45 to 64-year-old patients, these are the folks who are most at risk for complications in cardiovascular disease. We're doing terribly with these folks. We actually do a little better with our patients who are over 65 years. We're doing better with our younger folks, but this group here is really troublesome, and that's where we get a lot of our patients in that age group. If you look at Kaiser family analysis from the Organization for Economic Cooperation and Development data and compare the United States to comparable, industrialized nations, look how we're doing when it comes to diabetes mortality from 1990 to 2016. We're stable, but we're not comparable to these other countries. So these are countries like Austria, Germany, the Netherlands, Norway, et cetera. So the United States, there's something going on here where we're worse than a lot of our counterparts. Now, obviously, this is not going to be a talk about, economics so much and cost, but unfortunately, the way we've seen this during the pandemic as well, folks who are struggling to make a living, they tend to do worse with this disease. So adults with diabetes are more likely to report cost as a barrier to taking medication as prescribed, right? So if you look over here, these are diabetics whose incomes are below $50,000. And they're at the top here for people who are not taking their medications as prescribed. And you compare those to people just above 50,000, dramatic difference, right? 2/3 difference, right? It's really kind of disgraceful. Diabetic medications are the second most costly therapy class in 2018 that we prescribe. And a lot of these drugs should be generic, should be bioavailable, biosimilars, and the costs for a lot of these medications are going up. And there is a little bit of help coming along the way. It turns out that drugs like Januvia, sitagliptin, and Victoza, the first daily GLP-1, they're going to be generics in 2022, 2023. And that's really going to help us a lot. But right now, this is a big issue for all of us that take care of diabetic patients. And nobody seems to be stepping up to address it. If you look at employer-sponsored insurance, right? And the share of non-elderly adults with employer-sponsored coverage who say they or their family member with diabetes experienced the following due to cost in the past 12 months, you can see that a greater group that had themselves that were diabetics or a family member with diabetics put off or postponed getting needed health care. They relied on home remedies or over-the-counter medications. They hadn't gotten a medical test or treatment recommended by a doctor. Those were those patients that I showed you that I interacted with when I was on service. Hadn't filled a prescription. They cut their pills in half. This is something that I actually do for my patients. I did it for a woman this morning, right? It was for an SGLT2 inhibitor. I prescribed her 25 milligrams of Jardiance, and she's gonna cut it in half because her copay is too great. And I interact a lot with people from Big Pharma, not in our center, they're not allowed in, but I serve on boards. I'm the president of the local ADA community advisory board, et cetera. And there are people from Big Pharma on that board, and they keep telling me, oh, we've got all the formularies in the Delaware Valley are covered. We've got these drugs. And the truth of the matter is, yeah, they're on formulary, but the copays per month are just beyond the ability for people to afford them, right? So they can't get the meds. And it's not an uncommon thing for all of us who take care of patients for somebody to come in after 3-4 months and tell us, yeah, I'm not taking that drug, doc, because the price tag was just too high for me, right? And these are things that these people really need. Okay, what's the current status of diabetes care in this country? So if we think about endocrinologists as the people that take care of diabetics, we have nearly 8,000 endocrinologists. And remember, the majority of those endocrinologists are not taking care of diabetics, right? And this comes from the ABIM data from 2018. So that means if endocrinologists were just taking care of diabetic patients, there'd be 1 per 3,800 diabetic patients. And if you just do the math and you think about a large schedule of patients, 24 return visits per day, which is a lot, 4 days a week, which is reasonable, 16 weeks, because that's the interval from which they might come back to see you, That's 1,536 patients. And so there's no way we're getting close to that. And that's assuming all endos are focused on diabetics. So there are 22 million patients without an endocrinologist. And it's estimated, and you guys all know this, that 85% of diabetes care is carried out by non-endocrinologists, mainly primary care physicians who really struggle to deliver the care. The providers spend the majority of their patients' time in interaction with electronic health records rather than on face-to-face discussion with their patients, right? And the truth of the matter is, if I have all the data I need on a patient and I can just sit there and do the assessment and plan, that's a much more meaningful way of my expertise being applied to those patients, and that's not happening. So on average, only 16 and a half minutes out of the 35.8 patient visit time is spent on face-to-face discussion. That's a real problem. The ripple effect of an increasing diabetes population has led to increased costs, overburdened physicians. That's exposed the shortcomings of the traditional or the chronic care models that we really have to get away from, and they just don't work and don't apply to this disease. And again, the typical clinic visit is about 30 minutes, and that's conducted every 3 to 6 months. So the dilemma that we have. So we need to develop new models of diabetes care, and that's essential to accommodate the overwhelming number of patients while providing good quality of diabetes care. It's something that Dave Harlan's passionate about, I am too, and most of our colleagues around the country, but we're struggling to figure out how to do it. So where is the best diabetes care? We know where it is. It's in specialty diabetes clinics, like at the University of Massachusetts, run by endocrinologists, right? There are rare exceptions to that, but that's really where the best care is. What's the quality of care there? Generally, it's outstanding. It's really, really good. How are these centers doing financially? Poorly. We are cost centers. We are not cost saving centers. Now, with value-based care maybe coming in 5 years, more likely in 10 years, maybe that will change and we will become cost saving centers, but we'll see. What's access like to our centers? Deplorable, right? It's really hard for patients to get in to see us, right? And the reason for that is that our centers are clogged with return visit patients who want to continue to come and see us, et cetera. And a lot of them are actually doing fine and don't really need our care anymore. And I'll address that. What's the physician satisfaction like? Not good. It's really waning, right? And morale is a big source of problem for me with my crew. Patient satisfaction, better than average, I would say. When we do our Press Ganey scores, and et cetera, patients love coming to see us. And in fact, during the pandemic, and I'll show you the data, we were seeing mostly telemedicine, like I'm sure you guys were. A lot of our patients now coming back, we're at about 45% in person. And a lot of the patients have commented, and I think it's just because of the esprit de corps that we have in our center, that they missed our group and they liked to come back. So the patient satisfaction is wonderful. Is the current care model effective and efficient? Not even close. And we're doing a good job, right? What are the outcomes like? They're mixed, right? I mean, we take care of complex patients. We're a quaternary care center. We do fairly well. We do a lot better than primary care, but we're not, universally great. Where do we need the best care? Probably in primary care practices. And if you go back up and you ask yourself, what's the quality of care like in a primary care practice for diabetes? It's generally lousy. How are they doing financially? They're just like us. They're poor. They're cost centers. What's access like? Well, it's a mixed bag, right? Some of it is not bad because a lot of these patients are already embedded in some of these practices. But right now, we have a real dearth of primary care physicians all over this country, and patients can't find a primary care doctor. What's the physician satisfaction like? Worse than us. People are leaving primary care in droves. They're getting recruited away from academic centers. It's a big problem. What's the patient satisfaction like? Worse than ours, I'm pretty sure. Is the current care model effective and efficient? No, not even close. And what are their outcomes like? Deplorable. I mean, they're really bad. And I'll show you some of that data. So, in light of that, some of the things that we've tried to do is provide some CME to our colleagues. So this is a web cam that we did recently, a webinar, I'm sorry, to address our primary care providers in specific, management of type 2 diabetes care, expert guidance for challenging cases, and we got tremendous uptake. We probably had 180 primary care physicians nurse practitioners, care providers. This is our faculty. Serena Cardillo was the person who organized this. You can see that I'm the token white male here, right? So they needed one, so they found me. And because, you know, there just aren't enough white men in senior positions around academic healthcare centers. So these are the educational objectives, stuff that you guys know backwards and forwards, but we're trying to help our primary care colleagues with. Apply clinical care guidelines to treatment because they're not doing that. Incorporate patient-specific factors, including comorbidities, you know, and try to individualize treatment plans. Provide approach for navigating the growing number of available therapeutic options, newer agents, SGLT2 inhibitors, and teaching them about CGM. And I'll show you some stuff on that. So recently, I gave a talk to our hospital board about diabetes care at the University of Pennsylvania and kind of a broad-based view of what's happening in the United States. This was a slide presented by one of my colleagues, Matt Press, who is our healthcare system quality assurance safety officer. He's in charge of quality for all of primary care. And just wanted to point out to you, so this is the primary care service line at UPHS. And, you know, he makes the point, 62% diabetes uncontrolled due to no A1C in the last 12 months, because this is during the pandemic, large portion controlled at last check. But you can kind of see where these numbers are running. So they've improved a little bit recently at some of these practices. This is Clinical Care Associate Group. This is CPUP practices. This is Princeton Health, where we've been for several years. But these are the percent of patients who have A1Cs that are greater than 9%. I mean, staggering numbers, right? 37%, et cetera, 28%, 31%, really not good. But they're really proud of the fact that they track other metrics such as an annual eye exam. And this shows it sort of in a different picture, right? So yeah, it's true that a lot of people haven't had an A1C, but let's just take the people who've had A1Cs that are not controlled. So greater than 9%, 37.27% of all the diabetics that they care for. I mean, it's really bad. In our practice, our type 1 diabetics are somewhere around 8 to 9% here, and our total is somewhere around 15%, right? But remember, we're taking very challenging, complex patients. Now, Alona Lawrence, who's our quality assurance officer in endocrinology, did this really nice sort of look at medication usage in diabetes and heart disease from November 2018 to November 2019. So this is pre-pandemic. And she looked at, this is UPHS. So this means this is our primary care colleagues and what they're doing. And this is after we had done some CME, we had worked with them, spent time with them. This is their percent use of DPP4s, 11.8% of all their diabetics, incretin mimetics less, SGLT2 inhibitors about 5%, compared to metformin, compared to insulin, and then to other drugs that they're more comfortable with, like statins, ACE inhibitors, et cetera. And there was no change over this period of time whatsoever, despite our efforts to intervene. This is our group, right? So we're 2 to 3 times the health system levels for all of these drugs, right? We still do a great job with statins, ACE inhibitors, et cetera. Obviously, we're prescribing more metformin and a lot more insulin, right? But this just goes to show you the deficit and the differential in the level of care. So what are untapped resources? So this is data that we got over this past year, just looking, because in diabetes care, there are very few things that you can do that actually generate money for your practice or your center. So we're getting about $60 for our 95251 code for CGM interpretation. Our Rodebaugh Center in fiscal year 20 billed 1,700 interpretations, and that generated $103,000 that we previously were not getting, right? And when I have staff meetings with my group, we talk about this, we make sure everybody knows the code. I've sat down with everybody that bills in our center and in our outlying centers as well, because we're all over the Delaware Valley, to make sure everybody is doing this. Fiscal year 21 through April, we billed now 2,626 interpretations. Now we're up to 157,000, annualizes to $190,000. Think about what you can do with $190,000. You can almost hire 2 nurse CDEs for that, right? Not insignificant. Here's the graph that just shows the growth, right? So this is what happens when you really harness technology And some of this was necessitated by COVID, but you can see even before that, we were in an upward trajectory, right? And this is something that I'm part of a diabetes disease management team at Penn, and that's run by a quality assurance primary care doc. And you wouldn't believe how difficult it is for me, and I've been working with these guys for 3 years, just to convince them that they need to use CGM in their practice. And just to give you an example, I sent emails out with CC, the two sales representatives for both Libra and Dexcom to two physician leaders in primary care here. One of them had a visit from the Libra guy, hasn't yet contacted the Dexcom person. The other woman, 3 months later, still hasn't met with the Libra people, hasn't done anything to get this stuff on board. And what people ask me often, in fact, I was asked this question when we did the webinar, well, how do you get this into your practice? It's the easiest thing to do. And I tell people this, the companies that make these two CGMs, they're just chomping at the bit, sitting there waiting for primary care doctors to invite them over. And they do everything for you. They will help you download the software. They'll teach you how to put the stuff on. Absolutely everything. They're at your disposal and they're there to help you. And there's just this huge barrier for doing this. And this is obviously, it's not the future of diabetes care. This is the present, and most of our colleagues who are primary care docs in this country are not embracing it. So this is a little bit of a depiction of what we've done during the pandemic to kind of increase telehealth efficiency and upload more technology. So we use Gluco as our software to get all our meter data to us. And then of course we use LibraView and Dexcom Clarity, et cetera. But you can see these are the total number of calls that we've done. And this is the number of calls per week. And you can see that it really started going up here early, a little up and down a little, but generally there's an upward trajectory. And then this is the available data that we have now. So we're getting upwards of 90% data on all of our patients that come in to see us. And we were able to do a lot of this because we got a grant from the Helmsley Charitable Trust through the Type 1 Diabetes Exchange, and they provided us with a grant of $45,000 to hire people. And then we were able to also partner with Cecilia Health, a health information company that helped us contact patients and get a lot of this stuff on board. So if you just look, we moved quickly from 0% telehealth visits in early March to 99% in April 2020, maintaining greater than 75% of visits as telehealth. We were able to quickly improve from less than 1% of patients uploading data prior to visits to 56% in a very short period of time, right? Like, in a month. And then we were able to max it out in April of 2021 at 75%. Our answered calls improved dramatically. The patients got accustomed to the fact that we were going to contact them, and the available data year average was 68%. Okay, so you can look at this data here. I mean, it's really impressive, and mostly thanks to the efforts by Alona Lawrence and Catherine Gallagher, who's one of our research coordinators here. Just spectacular work, and it's really made all the difference for us. So what can primary care learn from us? The answer is a lot, right? We are the experts. I like to call us mission control, right? And I just wish that healthcare systems around the country would avail themselves more of us, and they don't, right? Family practice, general medicine departments, practices, they should avail themselves of a diabetes expert as a consultant. And we have to figure out a way that our time that's invested with people gets compensated, and that's a challenge. What are the problems? So primary care docs, as I showed you from this data, they are late adopters of everything out there that's new and helpful. They're overwhelmed and under-supported, and there's a lot of misappropriation of resources. I was on the phone recently with Bob Gabbay, who's the Chief Scientific Officer of the ADA, and I asked him, what percentage of primary care doctors attend the annual ADA meetings? And he said it's less than 5%, right? So here you have care that's provided by 85% primary care docs, and they're not going to the meetings where they really need to learn stuff. An example of misappropriation of resources is the following. So in our diabetes disease team, I learned that they had hired 80 nurses to be care coordinators, right? Not to provide care, to call patients up regarding coaching, none of that stuff. All they did, and these are registered nurses who, you know, have a lot of ability. Their job was simply to make sure that patients were going to their appointments, checking off boxes to make sure they got their ophthalmology visits and things like that, but they were doing nothing to actually touch patients, talk to them about their diabetes, and improve their care. 80 people hired to do that. And to me, that is just not a good use of resources. So how can we simplify care? What's some low-hanging fruit? So these are questions in my mind that all of us should be telling our primary care docs that they need to do. And we do it without even thinking about it. It's just like completely rote for us. Is your uncontrolled type 2 diabetic with a creatinine clearance greater than 30 on metformin? If not, why, right? I mean, we've looked at this. Something like 40% of all of our type 2 diabetics who have a creatinine clearance greater than 45 in our healthcare system are not on metformin. Right now, there may be folks who can't tolerate it. I understand that, but that's usually not the case. Is your uncontrolled type 2 diabetic who is overweight or obese on a GLP-1 receptor agonist? If not, why, right? Cost is the major issue here, but it just should be somewhat reflexive that you're going to do that for everybody. Is your uncontrolled type 2 diabetic on basal insulin alone taking more than 0.3 times their weight per kilogram only on anything else? Why not add a rapid analog just once daily, or add a correction factor? Do something for those people. When I say uncontrolled, I mean people that have an A1C greater than 9%, right? And the data is very clear on this. If you just add a rapid acting analog 4 or 5 units with one meal, and it doesn't matter which meal it is, their A1C improves and their control gets better. Does your uncontrolled type 2 diabetic have a glucose meter? I mean, I can't tell you how many people who are uncontrolled, not doing well. It's one thing if you're on metformin and Januvia and your A1C is 6.3 and you're not having any hypoglycemia, God love you. You don't need to monitor your blood sugars, and you don't need to be in the hands of an endocrinologist. Is your patient who's checking glucose 4 times per day and injecting insulin 3 times per day on CGM? If not, why? Those people deserve to be on CGM. Our data tells us everybody who goes on CGM, on average, lowers their A1C in a 1 percentage point. That's better than any of the new drugs that are out there now. Has your patient enrolled in the diabetes education program and seen a dietitian? If not, why, right? But these are the things that plague all of us. We see this all the time in patients that are not doing well. And this is just, you know, diabetes care 101. And a lot of this country is not paying attention to this stuff. Can your practice download CGMs at the clinic or remotely? To me, again, you saw it was a Herculean effort for us to do this during the pandemic. I'm not saying it wasn't, but that's an investment that's really worth making, in my view, and it's not happening. So non-traditional care is the future, right? So what we're doing now is not working. So ultimately, telehealth, e-health, mHealth, they may lead to reductions in overhead costs, administrative healthcare expenses, and it's something that we really need to think about and we really need to embrace. Leaders in the telehealth industry are actively creating novel tools to help patients to improve their diabetes self-management through virtual patient-physician interactions, and I will show you examples of that that are incredibly effective. Also, artificial intelligence may be a pathway moving forward. The COVID epidemic not only uncovered the importance of this technology, but it also gave providers and patients an unprecedented chance to experience digital health for the first time, right? So the thing that's very distressing to me is I just heard from our chairman of medicine that we are going away from telehealth and we are going to do in-person visits again. And he wants to get us to get back to 100% probably by mid to late fall. What's the cost effectiveness of telemedicine? So it may improve work efficiency. It saves us a lot of time and space needed to complete clinic visits, enhances patients' productivity by lowering the costs associated with obtaining care, right? Our show rate for telemedicine is almost 100%, right? We almost never have a problem getting in touch with patients. The development and utilization of connected devices like glucometers, CGMs, to mobile phones through mobile applications are rapidly progressing, and it's something that we all need to really embrace. Now, there are a lot of challenges with telemedicine, I won't deny that. There's uneven payment across payers. There are a lot of them that are not paying anywhere close to an in-person visit. There are cross-state licensure problems that create barriers to get telemedicine in place. The Federal Communication Commission is promoting telehealth though, and they understand that there are a lot of rural and urban areas in this country that really don't have broadband where they can use this efficiently. We've started a relationship with Comcast here, who's our major broadband and internet producer. They have lift zones all over the city, and they are very interested in, specifying these to zip codes where we know people have cell phones, but they don't have great cellular data plans. And that's one issue that we've noticed, that when we try to connect with these people, it's often challenging and the signal isn't very good, et cetera. And that's going to be really important, because if we're going to use all of these e-health devices and programs and everything else, we have to have a great way that's clean to connect with folks. So apps for diabetes care. Everybody talks about them. Everybody's creating one. We probably every year have 3 medical students that are creating an app for diabetes care. I just put some of these on here, went and looked around. 8% of type 2 diabetics actually use these. The people that use apps the most in our practice are type 1 diabetics. And yeah, if you have somebody who's OCD and likes their app and really uses this, and I'm happy to listen to other opinions about this, wonderful. But most people don't really use it the way that it's meant to be used. And they can be very helpful, I think. But in general, you're talking about folks who are type 2 diabetics, not because they're OCD, right? They've sort of unfortunately led a life that's led them to, uncontrolled diabetes, metabolic syndrome, et cetera. So I want to talk a little bit about Dave Harlan's, favorite topic, which is stability health. So we were very fortunate to start a pilot with Stability Health. This is Stability's, slide where they tell you we eliminate care gaps by partnering with patient and providers to enhance the care continuum. If you look here, this is how this works. Patients are enrolled, they're assessed by the Stability group, a care plan is initiated, there's data analytics, and all this stuff sort of, partners together. There's clinical information delivery, physician partnering with us, expert diabetes consultation, which is outstanding, engagement with the patients through data analytics, et cetera, and a lot of monitoring. All these things fit together really nicely. So their comprehensive solution works within the existing healthcare system by leveraging technology, tools, and diabetes expertise for the benefit of the patient and the provider. And we're fortunate that Stability agreed to do a pilot with us. And this is it. This is the process that we did. So we negotiated a business agreement, unfortunately, because Penn is slow as molasses when it comes to red tape, et cetera. That took several months. We started having biweekly and now monthly huddles, and then we enrolled 30 patients. So 2 of the endocrinologists that you saw in that photograph and myself each provided 10 patients. So we obtained consent, buy-in from the patient. We just did that verbally. We emailed the last patient visit to Stability. We had a patient physician satisfaction survey that was, in the middle of this and will be done at the conclusion. And Stability contacts patients and performs assessment. Stability provides physician with care plan, clinical summary, and recommendations. And it's worked incredibly well, very smooth, not a lot of paperwork hassle for us at all. There's engagement, expert diabetes consultation and monitoring, and regular submission of care summaries. And if there's an issue with a patient, hypoglycemia or something else, we get a message that comes right through our clinical care coordinator. So just to give you guys a little snapshot of what's happened. So 3 providers, 10 patients. Here's the breakdown of the diabetes type, which is pretty reflective of our center. 29% are type 1s, 71% type 2s, 14% are on pumps and CGMs, 11 just on blood glucose monitors, and 75% on CGM. Patient risk level broken down to high, 64%. So this was real world, right? I mean, we gave Stability tough patients, and that's what they invited and that's what they wanted, right? So these were challenging patients that I and my colleagues could not get under control. Here's what happened after 4 months. So since the pilot initiation, average decrease of A1C of 1.2%, body weight reduction of 2.64%. Anybody who's an endocrinologist understands when you improve glycemic control in general in uncontrolled patients, they are going to gain weight. These people lost weight, right? And really importantly, a reduction in the time spent in hypoglycemia. So I just wanted to give you an example of a patient. So this is somebody who I referred, who I struggled with for a long time. So she's a 61-year-old South Asian woman, presented to me for treatment of her type 2 diabetes with dyslipidemia, hypertension, and microalbuminuria. Her age at diagnosis was 46, right? And I've been taking care of her for probably 8 to 10 years. She worked as a postpartum nurse at our hospital, and her BMI ranged between 27 and 29. She was on metformin, extended release 2 grams a day, Januvia 100 milligrams daily, Novolog 16 units with breakfast and lunch, 13 to 14 with dinner, plus a correction factor, and Levemir 36 units. Can't tolerate GLP-1s. I had added pioglitazone because I was getting desperate, and a lot of people who are South Asian, they have that hepatic insulin resistance problem. She didn't start it for whatever reason. At the time that this is what she was on when we referred her to stability. And her A1C at the time was 7.7, not horrible, but it had been higher. And here's the impact of a coordinated care management system like stability, okay? So here's her Dexcom back in November before we referred her when she was on the regimen that I showed you. Here's her average glucose, 191. She's in target range only 46% of the time. And this is what her AGP looks like. Here's the stability health intervention, right? Nothing from me. This is all stability. They improve her diet. She loses 2 pounds. She stays on the metformin and Januvia. They reduce her insulin, and now she's eating a salad for lunch, which she wasn't. Her Levemir is down to 30 units, and her aspirate insulin's been cut about 4 to 6 units across the board. And look at her AGP thanks to stability health, right? She's now in target range 83% of the time, and her average glucose is 137. And what does she say to me? I've never felt better. My energy level is fantastic. Thank you so much for referring me. So kudos to everybody at Stability Health. Really fantastic, right? And what's the key to this? The key is that despite all the resource that I have, I could not improve this woman, only to a certain level, right? What did she need? She needed multiple touches. She needed coaching. She needed something that I don't have, that's currently not compensated for in the American healthcare system, right? But look at the value that you get out of that. Now, this is a different health information company. This is Virta, so a competitor. This is a patient of mine who, through work, was able to get Virta, right? So she's a 59-year-old woman, 7-year history of type 2 diabetes, no complications, has hypothyroidism, dyslipidemia, and hypertension, was referred by her PCP to see me 5 years prior. She attended an education program, saw a dietitian, and these are the medications that she was on, not able to tolerate metformin. 6 months ago, she weighed 191 pounds, had a BMI of 32. Her A1C was 7.8. These were some blood sugars that she had back in September of 2019. I mean, these are really not great, and she wasn't monitoring all that much. And back then, her A1C was 8.9. She went and tried to use Weight Watchers, lost 15 pounds on that, but she regained it in 2 to 3 months. She got Virta as a benefit through work. She works at Comcast, one of the largest employers in this area, and they provide a benefit for her. Now that's wonderful, right? Because she's a woman who makes over $100,000 a year. She's got a great job. She's got a company that cares about their employees. And so they provide her with this option that you can sign up for. And what she told me was a lot of her colleagues who are diabetics elected not to sign up for this. I'm not sure why, but they didn't do it. As part of Virta, she gets a physician and coach. Not me, somebody else. She lost 20 pounds, and these were her labs after the intervention, right? So her A1C dropped to 6.5%, and she was off all her diabetes medications and felt great, right? Why did this happen? Because of the coaching, the intervention, the constant help, the constant touches, right? Which this woman responded beautifully to, right? So again, another example of what we really should be doing for a lot of these patients that we can't do today. Just wanted to mention the Joslin HOME, which some of you guys may be familiar with. So again, this is sort of another model and another approach, somewhat similar. So this was developed in collaboration with Joslin and the American Well Incorporated. It's a telehealth company, and they similarly address gaps in the current classic clinic visit. And they identified these two major problems: waste of time of the visit at the expense of direct face-to-face contact, something that we all realize is a problem. And they looked at the relationship between the frequency of visits and the time needed to achieve glycemic and metabolic targets. They eliminated most of the time used on the medical record and shifted to a focus and precise documentation. They increased the frequency of visits while shortening their duration, right? Very challenging to do. It's something that Stability and Virta do. Consider the wasted overhead time and the cost in scheduling and canceling visits by using electronic technique instead. It's a scalable program, provides continuous and on-demand assistance that aligns with demands for chronic disease, right? They also provide an accredited live and online training program for diabetes care physicians and other supporting healthcare providers. They also have an option, if you're a patient in this, that you can sort of choose your care team and pick from a menu of this person, that person, et cetera. I'm not sure that that's really effective and if that's really going to work, but that's what they do. But just to give you some of their data, right? So if you look at the impact of visit frequency on the duration taken to reach A1C, if you're seen every 3 to 6 months, to get your A1C down below 7%, it takes 25 months. Whereas with their intervention, it takes 4.4 months. A1C less than 7% on no insulin, 1 to 2 weeks, 10 point. This has got to be the opposite. This has got to be greater than 7%. 52 months it took if you were seen every 3 to 6 months. In their hands, 10.1 months. And then they give you blood pressure and LDL is left, right? So these are the main differences between the classic chronic care model and their model, right? So long visits in the classic care model, something that we always do, we have to do. Their visits are 5 to 15 minutes. Frequent visits, 1 to 4 weeks. Rigid schedule, flexible two-way schedule, right? They make it easy for the patients. Low overhead costs, really important. Travel time and costs for patients, really almost eliminated. Suitable for pretty much every patient. And I think that that's true. I think that this kind of care makes access much easier. So harnessing the diabetes care expertise, what do we do to kind of make things better? So traditional care, obviously outdated. Clinical experts should provide assessments and more so management plans. Nurses can convey information to patients and implement the care plan. That's something that I'm a huge fan of. And this is just like a really basic model, but this is the way I think about how we should be using our diabetes experts, right? So, instead of us having a schedule with, 12 patients on it or something like that, we should just be supervisory experts who have a group of people, and those are advanced practice providers, nurses, they could be fellows who work with us, maybe primary care physicians who are training with us to learn how to do diabetes. These are the people that should be getting all the data for us on the patients, either through telemedicine or live in person, and they should just present it to us in a very quick, concise way. And what we should be doing is spending 5 minutes or less with each of these patients. And I know that sounds a little harsh, right? But we've got an epidemic on our hands, right? And if we did this, we could reach so many more patients, because all of you who take care of diabetics know this, right? It's not rocket science. It just has to do with experience, right? And if you just apply your expertise, for the most part, you can assess what's going on very quickly. You can come up with a management plan, and that's what that patient needs from you. They need other things from these people. They need multiple touches, et cetera, from a lot of these folks. We have a nurse who actually wants to do something like Stability Health or Virta. She can't get compensated for that. She loves talking to patients on the phone. She's a type 1 diabetic herself. We actually have access to an endowment, and we may be able to fund 50% of her job to do that for us. That's on a small scale, but this is a model that I think we should all be thinking about. So improving care access, and this is sort of the end of my talk, right? We want to improve access and quality, but this is, oops, sorry. Sorry about that. There we go. Okay. So we have to enhance and embrace telemedicine. We're already being told that telemedicine is going to go away, right? So all of us have learned so much through the pandemic, right? And if we don't do something as a group to advocate for more telemedicine as a methodology of seeing our patients, we're really going to lose out, and they will too. Integrating data from web-based platforms, critically important. I mean, you saw this, right, with all the outreach that we did to patients. The help that we got from Cecilia Health really makes a difference. Partnerships with health information companies like we've done with Stability, with Cecilia, et cetera. We need to do more of that. Diabetes disease team. So this is the primary care group that I've been working with for a while. What's my role? Content expertise. And what am I going to do there? And all of you have to do this. You got to influence them and you got to woo them, right? You have to convince them that they need to go in a different direction, as do we, right? Diabetes optimization consults, right? So we can't see and take all these patients on into our practice. What we can do is if these folks are referred to us, we can assess them. We can come up with a management plan, which we can very quickly print out, provide to them, send to their primary care doctor and say, this is what this patient needs to do. I did this last week in an executive health sort of capacity for a man who works for the UN, but is from Iraq, comes to this country every 6 months, just wanted somebody to take a look at his diabetes, metabolic syndrome, and I prescribed nothing for him. All I did was I put together a care plan for him. I said, this is what you need to do, right? All of us need to be working in that capacity. Partner with corporations, right? So we're partnering with Novo Nordisk, Comcast, Walmart. Why? So that we could have kiosks so that that young woman who was 24 years old and ran out of her insulin and nearly died has a place she can go to get some free insulin and make it easy for her. Companies like Comcast need to help us with better broadband access for our patients, right? The way that we're going to be interacting with these folks in the future is not going to be in person. It's going to be online. We have to make sure that those people have access. We have to educate and support our primary care providers. That's our job, right? I used to think to myself when I took over as medical director, I'm going to take care of all the diabetics in the Penn healthcare system. Impossible, right? There are, you know, way too many of them for me to care for. So I disabused myself of that very quickly and figured out there have to be other ways. So we've done a lot of e-consults over the past 2 years. I'm sure you guys are doing that too. For a while, Blue Cross Blue Shield was reimbursing us for those. They're no longer doing that. Our Department of Medicine thinks that those are a great idea, and they're actually reimbursing us for the e-consult. So, you know, our primary care docs send us an e-consult right on Epic, which is our EMR. All the information data is there. It takes us 5 minutes to come up with a response, send it out to them. They love it. Patients love it. The patients don't need another visit, right? And these are often sort of simple questions. I got a patient who's a pre-diabetic, you know, should they be on metformin or not? Just things like that. I got a patient who's on MPH insulin twice a day. His A1C keeps climbing. What should I do next? We need to embed our diabetes experts in primary care practices. We just recruited one of our fellows to stay on to be a diabetes endocrinologist with us. And part of the package was that we were going to get support from the healthcare system and general internal medicine for her to spend a certain proportion of her time in a primary care practice, and one of the busiest practices that we have. Not to have a schedule, but to be there as a content expert to support, train, and teach primary care providers. And a part of that is training primary care nurses and NPs. So this is something that we do in our center, and we invite folks all over our healthcare system, come and hang out with our nurses. If you're a nurse practitioner, come and spend a week or two with our nurse practitioners and our doctors, and we'll teach you how to do diabetes care a little better. So some of the new visit models that we're trying to embrace are pre-populating charts. So when I go to see a patient now, I've had a nurse who's already met with the patient over the phone, has pre-populated my chart my template, so everything's in there for me. All I have to do is briefly go through, ask some questions, meet the patient, and I quickly can come up with an assessment and plan. That makes so much more sense. We need to do more of our care online. It can be done after hours, et cetera, et cetera. Online education, right? So this is a gift that we're providing to our healthcare system, right? We took our diabetes education program and we put it online so it's accessible to anybody, actually not just at UPHS, but anywhere in the world. They can get on our program. It's roughly 8 total hours of time, and it's indexed. And it's not meant to replace an in-person education program, which we know patients love and value more than doing things like this online. But it's just to serve as a supplement, right? Here's something else that you have if you forgot about something, or you're not a great learner, or you're hearing impaired or something like that, and you'd like to sit down and go through this again. Or maybe you'd like to go through it with a family member, a younger person, or your son or daughter, and learn more about diabetes. This is a great way to do it, right? And it's something, again, you saw how many of those patients that I interacted with when I was on service, none of them had had any diabetes education whatsoever. So for those folks as well, this is better than nothing. We need to initiate clinics that target uncontrolled type 2 diabetes. So I'm not saying that we should do this, but it's an option that our healthcare system has entertained, right? Let's just take folks who are cared for by primary care people, create a clinic just for them where they come in. It will be precepted by either a nurse practitioner who's really good and knows what he or she is doing, or a physician. And most of the care will be done by nurse practitioners and nurses, just targeted at uncontrolled type 2 diabetics. And that's all that will happen there. So it'll sort of be a mini Rodebaugh Diabetes Center, just sort of on a slightly smaller scale. Specialty pharmacies. So our pharmacy has been great with us, helping us provide medications, CGMs, insulin, et cetera, to patients who are struggling to pay for it. It's wonderful. It takes out the prior auths and everything else. We just send the prescription to them. They take care of it for us. And by the way, one thing that I have to say our primary care docs do really well is that they have a lot of pharmacists embedded in their practice that help them with these kinds of things. Another thing that is, a very difficult, challenging problem is all the uncompensated care that we provide to our patients, right? Unfortunately, we're not attorneys. We can't bill by time spent, but all of us are providing uncompensated care late at night, after hours for our patients. And I think if we had flexible scheduling like the Joslin HOME has, and we could just get these patients in as telemedicine visits very quickly, for 10 minutes or so, that would probably be a better way to address their problems. We need to train more diabetes experts. So this is a program that I'm really proud of. We've started a non-ACGME diabetes fellowship program. Some of my colleagues and I who work on a committee for the ADA recently sent in an article about this in Endocrine Practice. If you get a chance to read it, check it out. Below you'll see on our website an advertisement and sort of description of our Rodebaugh Diabetes Center Clinical Diabetes Fellowship. We have our first diabetes fellow starting next month in July. She's a woman who's trained in med peds and very much is interested in transitions in care. And she will basically be spending a year with us doing diabetes care, mostly outpatient, and she will have her own schedule, her own clinic. And the challenge for this is, how do you find a way to pay for something like this, right? There's no funding for it. There have been ideas about getting the pharmaceutical industry involved. I don't like that idea at all. I just think there's too many conflicts of interest there. The way that we solve this problem is to just say, okay, these are clinicians who are board eligible or board certified in internal medicine. They can bill for the services that they provide. We will start them out like we would with a nurse practitioner, with sort of a thin schedule with some new patients. They will be precepted by all of our faculty here, and they will slowly build up their census of patients and start to take care of them. So that's basically how we're going to accomplish that. So I'll stop there and happy to take any questions and discussion points that any of you guys have.